Yeah, thank you very much for joining us. I'm Adelina Comas Herrera from the Care Policy and Evaluation Center at LSE. And this is the first of a series of 4 webinars on a project called Social Care, COVID Recovery and Resilience. And what we set out to do was to learn lessons from the international responses to the COVID pandemic in long-term care systems. And today we're focusing on the Netherlands. The study is funded by the National Institute of Health and Care Research through the Policy Research Program. The views we'll express are very much those of the researchers and not those of the NIHR, the Department of Health and Social Care, the LSE, or the Nuffield Trust. And this project is a collaboration between LSE and Nuffield Trust, and Natasha Curry and I are co-leading. And all the people who've been involved at various points of the project are listed below. So thank you all. The aims of the project were to draw lessons for policy and practice from the international COVID-19 experience and also from scientific evidence to support the English social care sector. And the aims were to support it in recovering from COVID in the short term, to be able to better withstand future waves of COVID-19 or similar shocks in the medium term, and for the system to become more resilient in the long term. The project had a funny structure, so we started on the left-hand side of this slide by trying to understand what was there to learn about. So the thing is, yeah, we want to learn lessons, but what are the issues that we need to focus on? And to do that, we carried out a situational analysis of the English social care sector and the experience during the pandemic. And this was done through desk reviews and also interviews. And we also held a theory of change workshop, and we had various engagement activities. And as I said, quite a few stakeholder interviews that helped us understand what the key topics and areas where evidence was needed. So we identified these priorities. We'll talk to you a bit more about that. We carried out living mapping of scientific evidence on COVID and long-term care. And this was very useful and particularly lively during the earlier parts of the pandemic, where we were using this as a rapid way of identifying key evidence, new evidence even on the effectiveness of vaccinations, for example, and develop rapid evidence summaries that were, for example, used to inform some of the decisions of the SAGE Social Care Working Group, and also responding to specific queries from the Department of Health and Social Care. And after that, we have now been focusing on a topic that wasn't as well covered in the literature through a scoping review on the impacts of the pandemic on unpaid carers. And that's one side of the work we've done, but then there's this other side, which is what we're discussing today, which is how we can learn from other countries' experiences. We used the platform called LTC COVID to gather accounts of international experience throughout the pandemic. And based on that, and based on our understanding of what were the priorities and areas where lessons would be helpful, we chose 4 countries. And in those countries, we focused particularly on the areas of learning we thought would be useful for England. And we chose Denmark, and the Netherlands, France, Japan. And we're hearing about the Netherlands today. And the next step will be to co-develop policy and practice recommendations that are relevant to the social care sector in England. We are planning to revisit the theory of change and various engagement activities. We'll be sharing our email addresses. If you'd like to be involved in any of those activities, please let us know. So that was an overview of the project. And as we talk about learning from other countries, I think a very important question, a very issue that we have to get out of the way is that it's really, really difficult to compare how long-term care systems performed in the COVID pandemic. There isn't any simple metric that we can use. It's also very important to note that there were no real metrics for international comparisons of performance of long-term care systems before the pandemic. So we didn't have any international database of how long-term care systems performed that we could call on. There were some measures that, of course, you could look at as one of them. And again, that wasn't easy to get the data, but one of them was to look at the deaths attributed to COVID for people who use or provide care. We could look, for example, at what happened to the continuity or the quality of care and support for people who draw on care and for unpaid care. So was the system performing in doing its job of providing care and support? And another set of measures would be to look at the impacts on the well-being of people who draw on care and provide care, but we don't really have any international comparable measures that would allow us to look at how different countries did on this respect. It's also very important to know that the COVID pandemic affected countries very differently, and then in that context affected long-term care systems very differently. Just to look at the 5 countries that we are considering at the moment, this is, as this slide is showing, the cumulative number of COVID deaths per 100,000 in the 4 countries that we're looking at. As you can see, the experience of Japan was very different than the experience of the UK. The experience of Japan and to a certain extent Denmark was very, very good, strong contention of the virus in the whole population at the beginning of the pandemic. And it was then later on that the virus had more significant impacts. And that's very, very different than France and the UK that had a much, much bigger hit very early on. So it's very important to understand that we're looking at these countries in very, very different pandemic contexts. The second thing I wanted to draw attention to is that even if you think we could compare how many people died in care homes, for example, for which we have some data, there are lots of difficulties with countries collecting the data in slightly different ways, but also the scale of impacts are very different. And the scale of impacts actually mirror very much what happened in the whole population. The slide on the left shows the proportion of people who are living in care homes at the beginning of the pandemic, how many would have died as a proportion. So and we look from over 10% for a few countries, including the UK, and much lower rates that was for mid-22 for Australia, Norway, and so on. And what's important to keep in mind is that when we look at, we might think we could rank countries like this, but in practice, what seemed to be the main driver, and this is the slide on the right, is that what we have here is on the bottom, we have the number of deaths of people who are not living in care homes as a proportion of the total population. And on the vertical, we have the number of deaths in care homes as a proportion of all the people who were in care homes. And you can see that there's a very clear correlation. And although there seem to be some differences between countries, I'd say that quite likely this is due to differences in measuring deaths. And what we see is that countries that had more deaths in the general population also had more deaths in care homes. And that is telling us that there wasn't any country that was able to fully contain COVID in care homes while it was rampant in the population, that although these measures that were taken to protect care homes were important, none of them was fully effective, and we don't see any examples of that. So with this consideration, I just also wanted to point out that by now, all the 5 countries we looked at all have had very high vaccination rates, with in Japan almost reaching 300 doses per 100 population, but all the countries we're looking at have at least on average more than 200. So yeah, people are at least on average vaccinated twice. So back on the other elements of performance, which of course are, how well was the system operating while the pandemic was raging. And we were able to use expert accounts from experts on long-term care. We had reports in LTC COVID from 33 countries, where we were able to read about the pandemic response in long-term care systems, what was working, what wasn't, according to international experts. We also know from the scientific evidence that there were some findings emerging that are very important. For example, that old-fashioned and large care homes did worse internationally, and also we know that the policies in place in many Asian countries were working very well in containing the pandemic, although things have become more difficult lately. So that's what I think we can learn from the evidence that we have, and doesn't give us clear answers. But now Natasha is going to tell you a bit more about how we thought about what the social care sector in England could learn. Natasha.
Thanks, Adelina. I'll just very briefly run through some of our findings from our England research, just to set what Nick and Joanna are going to be talking about in some context. So we started out with trying to understand what happened in the English social care system at the beginning of the pandemic, to understand what it was revealing about the problems and weaknesses in our system. I think the first few weeks really exposed a lot of weaknesses in the system, many of which we knew about before but had not been addressed. We think these are priorities for reform as we go forward. So through a series of interviews and document analysis and workshops, we've unpicked the factors that we think shaped the response. And we've identified 3 groups of priorities for the English system. And we've used this to shape the rest of the project and the choice of our case studies. So just briefly on these, we think there are some real lessons that we can learn around how the system works and how it's structured. There were real problems in the English system in understanding which organisation, who was responsible for which part of social care, and a sense that social care was quite invisible in that in those first few weeks, which I think speaks to a longer history of where it sits in priorities within central government. There was a set of lessons around the diversity and complexity of the system, and the response not really grasping how complex this population is in terms of the people who draw on care and the workforce. One example being that the fact that a quarter of the workforce in England is on a 0 hours contract and therefore didn't have access to sick pay was a really fundamental issue that was overlooked in some of the policy making and guidance. And then finally, there's a collection of learning around resources and the stability of funding in the English system. And what we saw during COVID, which I think is mirrored in regular times, is that social care tends to be propped up by sporadic injections of cash with no sort of stability and certainty of that funding. I think that really undermines some of the responses and stability in the system. And what we'd seen in the years preceding COVID was a lack of investment in the infrastructure. So at the point at which COVID hit, our infrastructure, and particularly our care homes, were not very well set up for dealing with a pandemic such as COVID. So we've used these sets of priority to guide our thinking about international case studies. Adelina, can you just click to the next slide, please? And so we did a high-level mapping internationally to look at, well, where might there be some relevant lessons? Where might we be able to learn, translate some of the experiences of other countries, both positive experiences and not so positive experiences? And from this high-level mapping, we've identified 4 case study countries: France, Japan, the Netherlands and Denmark. And today we're going to hear about the experience of the Netherlands. And so I'm going to hand over to my colleague Joanna and Nick, who's joining us from the Netherlands, to run through the learning from that country. Thank you.
Thank you very much, Natasha. I'm just going to share my slides with you. I might need some help with that as well, because I'm not sure that I've it tells me, Adelina, the host disabled participant screen sharing. I don't know whether you can enable that, or alternatively you'll have to share my slides.
You want to try again?
Okay, thank you. Can you see my slides as a slideshow, or?
No, they're in not slideshow format.
Okay. What about now?
Yes.
Yes.
Okay. Right, so my name is Joanna Marczack. I'm part of research team working on the Netherlands, and with me today is Nick Zonnenveld, from whom you'll hear in a second, but I just wanted to also acknowledge, Dini Stekelenburg and Hank Nies, who also contributed to the Dutch case study. So just very briefly, just why we chose the Netherlands. So initial literature review that we conducted suggested that there are potential lessons to be learned from Netherlands that could be of interest to England. There are things around the service users' rights that, especially a theory of change that we conducted in the project, suggested would be interesting for England. Issues around the topics around the workforce challenges the Netherlands experience, issues around the system, the fragmentation and coordination, use of technology, and last but not least also the availability of data. So in terms of methods, just very briefly, we did the initial literature review to explore the long-term care system COVID response in the Netherlands. And based on that, and together with our Dutch experts, we identified the key topics that we thought we could explore in more depth through interviews in the Netherlands. And that would be of interest to England. And then our Dutch colleagues, Nick and Denny, conducted 10 in-depth semi-structured interviews with representatives of people with care needs, with care organizations, public health organizations, and experts in long-term care. So in terms of the specific topics that we've been exploring in Netherlands, these included the topics around the rights of people using care and whether there's been any learning in Netherlands that could be useful for England, especially around the client councils. And in a second, I'll just explain in more detail what client councils are. We were interested to explore in more depth issues around workforce, in particular how far about the pre-pandemic as well as the pandemic measures to retain recruit workforce in Netherlands helped to manage staff shortages, as well as staff well-being. We were interested in exploring the coordination of pandemic response, the issues around governance, accountability, and whether there were any lessons to be learned and any post-COVID legacy. We were also interested in the effectiveness of integrated care, integration between health and social care system, including emergence of new forms of integrated care during the pandemic. So in the Netherlands, for example, the GPs were tasked during the pandemic to monitor frail elderly people. And last but not least, we wanted to explore whether and how the use of digital technology in long-term care sector has changed during the pandemic, and whether there was anything that we can learn from that as well. So I'm just going to start as well from giving people a short and brief overview of a long-term care system in the Netherlands, especially for those of you who perhaps not so familiar with the Dutch long-term care system. So Netherlands has got a relatively high GDP expenditure on long-term care. According to OECD data, it was 4.1% in 2019, which is quite high in OECD. However, there are obviously nuances in terms of what counts as long-term care expenditure, and in some cases, for example, in Netherlands, some of what could be counted as healthcare is counted as long-term care, but these things need to be bear in mind. In terms of the access to care, the residential care in Netherlands is needs assessed, and there are co-payments based on individuals' wealth and income, the co-payments towards the boarding. In terms of community care, some of it is developed to municipalities. So, for example, things like daycare centers, Meals on Wheels, or help with cleaning or adaptations. They are managed by municipalities. There are co-payments as well, which depend on the users' income and wealth. In terms of personal care, which is related to activities of daily living as well as community nursing, these are needs-based and they covered by the compulsory health insurance. So that's not means tested, that's covered by the insurance. They have regional care offices, which basically are representatives of care insurers within the region, and they contract with the providers, with the residential care providers, as well as the providers of community and personal care. Client councils are in all care organizations. So by law, each care organization in Netherlands needs to have so-called client council, which is comprised of either service users or the representatives. And again, by law, client councils have a say in the decision making in the co-organizations, especially in the decisions that impact the daily lives of the clients. But how it works in practice, we'll talk about that in more details today. In terms of long-term care workforce, a lot of people, over 50% of the long-term care staff works part-time. They're relatively well educated. So, for example, some of the care assistants have 3 years of vocational training. Netherlands has government subsidies for long-term care training. And in terms of the staff, so they have staff shortages in long-term care sector. There are 8 long-term care workers per 100 individuals aged over 65, according to the EU data. But that data doesn't kind of take into account the prevalence of part-time work. So again, that needs to people need to bear that in mind. There is a considerable outflow from the sector, and it existed prior to pandemic. So even before the pandemic, the Dutch government introduced different, tried to attract people into the sector. So, for example, they had image campaigns trying to make the sector a bit more attractive. They had stress management schemes or workshops which were supposed to help to retain the existing staff. However, despite of these efforts, they still have considerable staff shortages. So in terms of the general impact of COVID, the government in Netherlands was in general slow to deal with COVID outbreaks in long-term care. Healthcare was initially prioritized, and access to care was particularly hampered during the first wave. In general, for example, the Dutch Safety Board in September at the beginning of the pandemic stated that the health and the social care sector were unprepared for the long-term pandemic. What's also interesting in the case of Netherlands that they did have a national lockdown of institutional care facilities, but that actually led to a nationwide debate around the effects of the lockdown on the residents and on the professionals and on the well-being, and also debates around the importance of well-being, importance of how far the measures should go to protect vulnerable people and what are the trade-offs. In terms of mortality, I mean, Adelina showed some graphs already, but the excess mortality was just under 10% among long-term care users compared to 8.5% among the wider population. The care home residents accounted for around 48% of the total COVID deaths. That was in the data was from April 2022. In terms of the system response to COVID, in terms of the workforce, for example, the Dutch government had some extra funding for long-term care facilities to help them recruit unemployed and former long-term care workers and students. They also had things like they built an IT platform which helped to match the workers with the employers. They also had medical and nursing army staff deployed in very urgent cases. In terms of accountability, even the initial literature review indicated that it's a very fragmented system, and various bodies are responsible for both long-term care in general and infection control in particular. And Nick will show you a graph in a second with the governance structure, but in general, in Netherlands, the National Institute for Public Health and the Environment became a coordinator of the pandemic response, and they created an outbreak management team to advise the government. And there were other new organizations and functions which were created. They also have the 25 public health services, which have been in charge of general infection control. And again, in terms of coordination of the pandemic response and communication between the different levels of governance, the literature review at the very beginning indicated that it's been quite ineffective between the different levels of governments. And for example, there were no agreements in place on the role of representatives from long-term care sectors in advising on the national COVID response. If I can just quickly hand it over to Nick. Nick, can you just give people a quick overview of the governance?
Yes, of course. Thanks, Joanna. Well, we are looking here at a simplified visualization of the governance of the pandemic response. Yes. Sorry,
I do apologize. Moving in the wrong direction. Oh,
yeah, there it is. Yeah, although it may look not so simple when looking at all these blocks in colors, this is the simplified visualization of the governance of the pandemic response. When COVID-19 entered our country, many structures were activated. So they were already sleeping, so to say. They were activated when the pandemic developed. First, on a national level, as you already mentioned, an outbreak management team was installed, and that was one of the most important structures during the pandemic. The team was led by the National Institute for Public Health and Environment, and it straightly advised the minister. It consisted of many leading experts in the country, and in the beginning of the pandemic, these experts were mainly experts in virology. So I think that's interesting. And later on, this OMT got broader and broader, and they also added, for example, psychologists and economists, also people specialized in ethics. So all to include more views from society and make broader holistic decisions. So more below, on a regional and local level, there were 25 public health services, which were coordinating vaccination and public health related issues, and also 25 so-called safety regions, and these were coordinating the lockdown policies. These safety regions, they consisted of the majors of the cities in these regions. So these mayors are responsible for safety in the cities, and together they were responsible for safety in these regions. So, and there are a lot of things to say about this, but I think we will elaborate a little bit more on this during the lessons learned.
Okay, thank you very much, Nick. So as you can see, it's quite a complex governance structure. So if we can just move on to the lessons, which are based partly on the literature review, but importantly on the interviews that Nick and Danny conducted in the Netherlands. So in terms of the client councils, as I mentioned before, legally they have a right to be involved in decision making. However, at least during the pandemic, our interviewees told us that they were really not overall not involved in any decision making, especially at the beginning of the pandemic. In some cases, we've been told that they were kind of included in the crisis teams that were created and co-organizations. In some cases, they were asked for advice, but overall, the experience or the voices that we heard was that they didn't really have much to say, especially at the beginning. But as the pandemic progressed, both the family members and the client councils became quite unhappy with the lack of input in the decision making. And also, there were some national guidelines around the involvement of client councils in decision making published, and both the guidelines and the general unhappiness led to increasing involvement or participation of client councils in the decision making. And with that kind of experience, even though the focus of care organizations at the beginning of the pandemic was purely on infection prevention, gradually as families and the service users and the client councils became more involved in the decision making, and they had more voices, the care organizations realized that infection prevention might not be the most important goal for the clients, that there are issues around well-being and around the family lives that are also quite important. And for example, and overall, there have been lessons learned from what we've heard in terms of the importance of involvement of client councils and people with care needs in decision making. So, for example, after lockdown, the Dutch Ministry of Health invited the Federation of People with Disabilities to help them in decision making. So, as we've seen, there have been lessons learned, but I know that the issue around the client councils and people's involvement in decision making is quite a hotly debated issue, if I can say so, in Netherlands. So I'll just pass it over to Nick, if you can just give us a bit more details and up to date.
Yeah, I think you described it quite well already, Joanna. But I think the main issue here is that client involvement improved along the way of the pandemic. When the pandemic began, as in many countries, it was, well, as we say in the Netherlands, all hands on deck. And our government and the care organizations, they had to react to this chaotic situation with limited information available. So as you already said, client involvement wasn't a priority at all at that time. But when the pandemic continued, both our national government and care organizations, they made big steps in client involvement. And the things we heard in the interviews, our Minister of Health, for example, had a meeting with people with disabilities every other week, specifically concerning COVID-19 response. So with visually impaired people, hearing impaired people, people with intellectual disabilities, based on their inputs, the government started to change their communication styles and their COVID-19 strategies. So, well, and concerning the client councils, nowadays it is, as you said, mandatory to install a client council as a care organization. And before the pandemic, many care organizations already had one, but there's still a lot of variety how they actually function. So depending on the culture or the innovative nature of the organization, their size, also on the target groups, there's a lot of variety. If these councils, well, really have a serious role in these care organizations, but they are mandatory. Well, this law was actually enacted during the pandemic.
Thank you very much, Nick. Yeah, that's very interesting. I think that's a very interesting lesson, definitely, in terms of England. So I'm just gonna move on to the next lesson, which is around the measures to recruit workforce. And as I mentioned earlier, there have been numerous measures to retain and recruit workforce in Netherlands, both before and during pandemic. However, despite of all these efforts, the staff shortages actually worsened during COVID. And as we've been told during the interviews, the staff people are leaving long-term care sector for several reasons, but low pay was one of the key reasons why people are leaving for other sectors, which basically offer more attractive pay, as well as more attractive, perhaps, working conditions. So there's the low salaries. Again, we've been told that they have partly contributed to the declining of social status of long-term care, social care professionals. But the Netherlands also has challenges around the predominance of short-term contracts, also things about inflexible employment, and that all contributes to the to people leaving the sector. We've been also told by some of the respondents that it's really hard to actually deal with the staff wages for care organizations in the context of lack of government subsidies for long-term care staff wages. When the care organizations themselves are reliant on contracts from the care insurance or the government bodies in some respects for the income. But last but not least, what I thought interesting thing that came out of the interviews is around the workforce creativity and ingenuity. And we've been told that that was really crucial in coping with the COVID crisis, as different professionals developed innovative initiatives, for example, to manage the family visits or redistribute infected and non-infected individuals around the residential care facilities. But again, I know that the topic of the workforce is quite important at the moment and in Netherlands. So I don't know, Nick, whether you can comment on general staff shortages, but also the workforce creativity.
Well, this was during the pandemic, but still is a big issue. And there is still a lot of public debate about this in the Netherlands. I think if I look back at the interview, this is all about appreciation and acknowledgement of the healthcare workers. As perhaps in many societies, the social status of care professions is getting lower and lower. During the pandemic, suddenly there was a lot of attention for care workers. For example, in the Netherlands, we had a moment on, I believe, in March 2020, the whole country applauded for our heroes working in healthcare, working hard in hospitals and care organizations. However, after the pandemic, everything turned out to be the same as it was. So, well, a lot of care workers still suffered from the after effect of the pandemic, and the salaries were also still low. Although all healthcare workers received a bonus of €1,000, but their salaries stayed the same. And our Council for Public Health, which was also one of the respondents in this study, they published an interesting report with the title, "Applause is not enough." We really have to appreciate and acknowledge our care workers in a different way. And salary is, if we also look at our interviews, is a very important aspect of this appreciation and acknowledgement. That is what we heard in the interviews. But also flexibility. So, for example, to be able to get your kids from school or to school, or have a little bit more flexibility if you do not prefer to work in the evenings, for instance. And that's also why there are a lot of self-employed people working for higher wages now in the Dutch healthcare sector. So salaries and flexibility, because as you already mentioned, we are already world champion part-time working in the Netherlands. Concerning that last point, I think we should indeed acknowledge that the creativity of the workforce, of the healthcare workers, was indeed really crucial in coping with the pandemic. So, for example, during the lockdown, care workers invented new ways to deal with booking visiting hours. So there was this example where healthcare workers started using a booking system for restaurants to book the family visits. And a lot of care workers also managed to quickly learn about new technologies to, for instance, do video calls with family members when there was this nursing home lockdown. I think we should really acknowledge that it were the healthcare workers that cope with the pandemic, although policies were also important. So yeah.
Thank you, Nick. So yeah, I did find that very interesting, the workforce creativity and the importance role of that. But I think we'd better move on to the next lesson. So another issue we were exploring is the topic around accountability and governance. So as we've said before, it's a highly fragmented system, a differentiation of responsibilities across different levels. And it's very complicated, and as we've been told, although the boundaries between the different levels of governance are supposed to be described clearly, there are loads of grey areas, which makes it really hard to coordinate the system and the response. And we've been told, for example, by one respondent, that the COVID crisis exposed these shortcomings of the system really ruthlessly. There have been also, we've been told, a lot of tensions between different levels of governance in terms of them having different policy views or different interests, etc. So, for example, we've been told about the frictions between the national government the national COVID policies and the lack of support for these policies at municipality level. And again, Nick, I don't know whether you want to comment on that, because I know that was quite unprecedented when the municipalities, for example, didn't necessarily follow the national law.
Yeah, maybe a really short comment also. Because of the time, but yes, I think that was a really unique situation. I never saw that before. We have a very decentralized country with a lot of responsibilities and accountability for the municipalities on a local level. And during the pandemic, we also needed national policy, national control. And indeed, the most striking example was the refusal of some local governments to implement these national controls policies on lockdowns, especially on the countrysides where there were less infections. A lot of local governments decided to not follow the national policies that obliged them to close down nursing homes and restaurants, for example. Yeah.
Thank you, Nick. So another thing that we've been exploring is the collaboration and integration specifically between health and social care. So again, we've heard that the pandemic brought both the health and social care sector really close together, partly because of the shared enemy, partly because there were better financial resources. But post-COVID, if we can say that we are in a post-COVID world, that we've heard that organizations are going back to working in silos, collaboration is limited again, and that was partly attributed to limited financial resources, where organizations are back to competing for both the money and for staff as well. And in terms of the GP the specific example of the GP's coordination of the care of frail elderly, we again heard that it's still far from optimal, and it's partly because of the limited GP time. And again, Nick, I know there are loads of pressures on the GP time in Netherlands, so I don't know whether you have any comments about that, or the collaboration between health and social sector in general.
The interesting thing here is that the pandemic led to many new collaborations and networks between a lot of different sectors. So healthcare, social care, even housing. Organizations work together while they were trying for years, but it never worked before, and now it suddenly worked. So maybe an important aspect was that resources were pretty much unlimited. That made a lot of things possible. And as mentioned, they all had the same enemy, the virus. But yeah, the sad thing is that now we are back to normal. A lot of collaborations did not sustain. Health and social care organizations retreated again back to the four walls of their own organizations. Which is a pity. And an example of this is that GPs are currently under a lot of pressure. They are an important gatekeeper in our health system, but they really need other parties to collaborate with to be able to do their job. So healthcare, social care, as I mentioned, housing, social services. The GP cannot do everything, and currently they have to do pretty much everything in our system.
Thank you, Nick. That's really interesting as well. So moving to the next, last but not least lesson around the technology. So as in other countries, the COVID sped up the use of technology in Netherlands. But what was interesting is that not all digital options were successful, and especially in dementia care. So as some of the respondents noted some of the technological solutions in terms of video calling, WhatsApps, etc., they really didn't work in dementia care, and they don't envision for their development in the dementia care. And we've been also told that in some respects they really appreciated, because of these developments, they really appreciated the importance of face-to-face care in some circumstances with some groups of people. But another lessons I thought were interesting is around the incentives to use technology. So for example, in some cases in Netherlands, we heard that the consultants were paid only for face-to-face consultations, not for online consultations. Obviously that acted as a discouragement. And also, interestingly, what we've heard is that in terms of making the technological solutions sustainable in the sector, it's the skills and the knowledge that are important to be considered, but also culture change. As people, both the professionals and the service users, can be quite fearful of novelties and of new technologies. So I don't know, Nick, whether you want to add anything to that.
Well, maybe very briefly. Yeah, the pandemic certainly has sped up the use of technology. But as you mentioned, there are many incentives that are still hindering that. And indeed, it's well, a great example is that there are still all policies there that make sure that there's only payment for literally seeing someone, so face to face. And this is from years ago when online consulting was still in development. But it's really important. We also heard that back in interviews to change that. And another thing we heard in our study is that well, the technology that has sped up the most was mostly the technology that is used by professionals communicating with other professionals. So we might also consider for the future that also a next step in technology that can be taken is technology that also can be used by service users and clients and patients.
Thank you very much, Nick. I think it's been very useful, definitely for me. And that's all the lessons that we've had. I realized that we don't have much time, and we've been talking for a lot. But if you have any questions, you can always email Adelina or Natasha or myself if you have questions around Netherlands. And you can also go to the LTC COVID website, where there is a lot more information and reports, webinars, and more. So thank you very much.
Thank you very much, Joanna. So I think
how do I stop sharing?
so
Oh, here, sorry.
That's great, thank you. And I noticed we have a question in the chat from Simon Bottery. Simon, would you like to pose it? And if you have any additional comment, if not, we can read it out. And if I see him. Oh, sorry, he can't come on camera. So the question is, was there a similar pressure to discharge patients from hospital to care homes, I guess? I'm interpreting the question in the Netherlands during COVID-19, and how did that work? Was that successful? I don't know whether Nick, you want to take this
well,
one?
I don't know how big this pressure was in the UK, but there certainly was, well, obviously a pressure in the Netherlands, and well, if it was successful, well, to a certain extent, the strategy was to discharge patients as soon as possible and let them recover at their homes, supported by a GP. And we also built quite a lot of recovery centers in the Netherlands. Well, event halls, for example, were organized to, well, create space for people recovering. But after all, we didn't need them. So, well, that's a good thing, I suppose.
Thank you. And I see a raised hand from Emily. I think Emily, yes.
I'm really interested in the part of the presentation that talked about, I guess, the evolving restrictions in care homes and how that was kind of influenced by the client councils. And I wonder if you could talk a bit more about how kind of visiting policies and approach to care home lockdown changed over the course of the pandemic.
So again, Nico or Joanna, I can just say one thing though, before, just that the Netherlands was the first country to publish an evaluation of the impact of visiting. So it was so in terms of research, it was also the first country that actually had an evaluation to know what was the impact in terms of infections, but also well-being of starting visiting again. And they did some pilot testing of that. Sorry, Nick, I jumped in, but you'd like to come in?
No problem. Yeah, well, if I understood your question correctly, you would like to know a little bit more details about how this developed. Well, in the beginning, it was, yeah, as I mentioned, all hands on deck, and there was little attention for client involvement and visiting. But I think during the pandemic, there was a big role also for the media and the public debate that really influenced thinking about what was worse, getting infected by the virus on the one hand, or on the other hand, well, the loneliness aspect. And I think that was quite well. In the Netherlands, we are always a little bit more debating also about broader issues than the medical side. So I think that was quite unique in this situation.
Thank you, Nick. Joanna, you.
Can I just add to that? What I also found interesting, and that's based on some of the research in Netherlands that's been done, is that actually the lockdown, that there is research that it had negative effect on the care professionals, because they felt that the restrictions were just too strict, and they were really internally conflicted with actually abiding by the lockdown and by the restrictions. So I thought that was also interesting.
Thank you. And I see Caroline Abrahams.
Hi there. Thank you so much for that. It's really, really interesting. You explained the role of client councils in your system, which are very interesting, I think, for us here. And then you also mentioned how there are now meetings with groups representing people with intellectual disabilities with the minister and so forth. I was wondering what happens about the representation of older people's voices within the Dutch system. Where is there, do you have something like a commissioner for older people? How are older people's voices heard within the system, or indeed within your system of government?
Yes, thanks very much for this question. I think at the moment, well, we really have to make a difference between the pandemic and the situation as it is now. At the moment, there are several councils and also organizations in which are older people representing them in Dutch national policies. to be honest, I am not quite sure whether these councils or representatives of people with disabilities or older people still meet with the minister and how often. This was really a specific pandemic thing. So I honestly don't know whether these are still well, meeting. I'm not sure, but they are there in the system, and they have. I can post a couple of links of our representatives of older people in the chat if you are interested.
Thank you. Yeah, that'd be good.
Thank you. And I see another question in the chat. I'm not sure about how pronouncing the name. I think it's Braubach. It's what next steps do you plan? I'm assuming this is for the Netherlands, or if it's for the project, please let us know, to improve the situation in long-term care in further pandemic situations or other crisis situations. As well, are there any plans to develop planning, and I'm assuming for other crises, and to improve the resilience of the Dutch system? Are there any changes, any policies that are being discussed at the moment?
Well, at the moment, there are a lot of studies going on evaluating the pandemic and the pandemic response. And of course, there are a lot of critics, as there are in a lot of countries. And there's also, although the pandemic is already quite some time behind us, there is still a public debate about the extent to which we still have to be prepared better. And there is, well, the interesting thing is that actually our coordinator of the pandemic response from a hospital point of view is now our new Minister of Health. So he experienced COVID-19 in his hospitals and at the intensive care quite closely. And he's working on a new pandemic response policy. So, well, that is promising. But well, naturally, there's also a lot of criticism about how things are developing.
Thank you very much. I think that's probably the last question we have time for. I just want to remind you all that we've got another webinar led by Laura Schepler and with Professor Tina Rosgaard on Thursday, looking at Denmark. And then next week we'll be meeting with an expert from Japan, and then in a couple of weeks we'll be looking at France. And as always, the lessons are positive, negative, and can go in both directions. So thank you very much for joining, for the excellent questions. Particularly thanks to Nick and Joanna for taking us through this very thoughtful process of trying to draw lessons from such a complex situation. So see you hopefully in the next webinars. And if you have any comments for the team, please feel free to contact us.